Good evening, everyone. Thank you for joining us for tonight's IDF Forum, COVID-19 and update. So as always, a disclaimer that the information presented during this evening's event is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Please always seek the advice of a physician or other qualified health provider with questions concerning a medical condition. So on behalf of the Immunodeficiency Foundation, this is the official welcome. I'm Kathy Antela, Vice President of Education, and I will be your MC tonight. So whether this is your first forum or your 100th, we are so glad to see you. The mission of IDF is improving the diagnosis, treatment, and quality of life of people affected by primary immunodeficiency through fostering a community empowered by advocacy, education, and research. This means that we are committed to serving you and providing you with the tools and resources needed to be your own best advocate and a champion in the PI community. It is by offering these tools and resources that IDF can fulfill its vision of seeking to ensure that everyone in the United States affected by primary immunodeficiency has a fully informed understanding of the PI diagnosis that affects them, all available treatment options, the expected standard of care, and all the opportunities for connection and support within the PI community. It is by offering all these tools and resources and events such as this one tonight that we thank our sponsors. Our wonderful sponsors make these events possible. And I would like to take a second to thank our 2021 sponsors: CSL Behring, Grifols, Takeda, Horizon Therapeutics, Octapharma, Accredo, ADMA Biologics, Bioproducts Laboratory, Farming Healthcare, X4 Pharmaceuticals, Kedrion Biopharma, and Celio Health. So walk season is upon us, and this is the time that funds are raised for research and programs at IDF, and it is a great time for family and friends to learn about PI and to support the programs available through the Immunodeficiency Foundation. So if you have not registered yet, please do www.walkforpi.org. And we look forward to seeing you virtually and then involving you in as many ways as we can. Oh, by the way, if you raise just $25, you're going to get an awesome IDF Walk for PI t-shirt. So that sounds fun. So therefore, really important to get that $25 donation and get that t-shirt. Upcoming events: IDF Get Connected groups. Our small networking groups occur virtually throughout the nation, throughout the year. There are specific groups for parents, adults with PI. You can meet other people who live in your region, or you can meet people who live throughout the United States. So please check out the calendar of events. And if you have not joined a Get Connected group, you might want to try it. Coming up this month, more forums. Next week, Thursday, October 14th, what's special about a specialty pharmacy? Join us for that. And then we're taking a week off, but the week of October 25th, we have 2 forums. One is Plasma, a lifeline in the PI community, Tuesday, October 26th. And then the same week, Thursday, October 28th, IG replacement therapy. So all of our events are available on the calendar of events. And as soon as they're open for registration, which tomorrow, the specialty pharmacy forum should be open. Please register. The other two listed here will be open probably by the end of the week. So check that out. Emails will also be sent once registration is open. At this time, I would like to introduce our presenters, Dr. Kathleen Sullivan. She is board certified in pediatrics and pediatric rheumatology, and she is the chief of the Division of Allergy and Immunology at Children's Hospital in Philadelphia. Dr. Sullivan has written or co-written over 200 publications in medical books and journals, and is the vice chair of the Immunodeficiency Foundation Medical Advisory Committee. And I would also like to introduce and welcome Dr. Maria Gutierrez. She is board certified in allergy and immunology and pediatrics. She is an assistant professor of pediatrics at Johns Hopkins Medicine. Dr. Gutierrez's research interests include immunodeficiency, autoinflammatory syndromes, and childhood immune development. So please join me in welcoming Dr. Sullivan and Dr. Gutierrez as they present an update about COVID-19. Thank you.
Thank you very much, Kathy. So as Kathy mentioned, Maria and I are going to split duties. So Maria is my good friend and colleague down at Johns Hopkins. And the way we have divided this, as Kathy mentioned, is Colleen and Kathy got hundreds of questions, and we tried to sort of assemble them into different themes. I'm going to be talking about COVID-19, the condition, as well as some newer data about risk factors specifically for people with immune deficiency. And then I'll turn it over to Maria, and she is going to talk about vaccines and some of the newer data on vaccine efficacy and immune deficiencies. And so with that, I'm going to go ahead and show a couple of slides that I have shown before, just to remind you of some of the unique aspects about the SARS-CoV-2 virus. So the SARS-CoV-2 virus is the virus that causes COVID-19. And it's a little bit unusual among respiratory viruses for this very prolonged time frame. And so from the moment of infection, there's almost a week before people develop symptoms. And of course, there's a lot of people, maybe as many as half of the people that are infected, that have either no symptoms or what we call paucisymptomatic. They have very few symptoms. But among the people who develop symptoms, it's usually about 5 to 7 days after the moment of infection. And that moment of infection is actually a huge variable in terms of what happens down the road. Now, we can't really measure it, but we know from laboratory mice and other models that the more virus that lands in the nose or in the mouth, the higher the likelihood of progression to severe disease. But we can never measure that in retrospect. So there's this, so just to recap, from the moment of infection, there's almost a week where this virus is penetrating our cells and starting to infect our bodies, and we don't even know it. And then for about half of the people, there are symptoms. And then we sort of decide what our body is going to do over the next 1 to 2 weeks. So there are people that progress very quickly, but the majority of people are either going to have a gradual recovery in that 1 to 2 week period, or they are going to be hospitalized and even go to the intensive care unit. But you can't really tell at the moment the patient is in the exam room or in the emergency room which way they're going to go. And that's really quite an unusual aspect about this condition. So this, we know, because people have been studying this so intently, that during this asymptomatic incubation period, before people even know they're sick, we can tell immunologically that there are some differences. So there are, if you swab out the nose of the people that get better, already our bodies are responding to that virus, even though we don't feel sick. And the people that ultimately go on to recovery have very high interferon lambda. What is that? So the interferons are some mediators, or you can think of them as hormones, where the cells tell all of the surrounding cells, oh my gosh, there's a virus, you need to put up your antiviral walls. And in the folks that recover, there's a lot more interferon stimulated genes than in the ones who go on to get severe disease over on the right. And so already during this asymptomatic period, you can tell which way the patient will ultimately go. So just a few more words about interferon. So interferons are actually the oldest known sets of cytokines. They were originally discovered in the 1920s, believe it or not. But these cytokines, it's just another way of saying immune hormones. And interferon, if you give extra of it to someone as a therapy, so interferon can be used as a drug. If you give people interferon at the beginning of their infection, it shortens hospitalization. So we know that interferon is important. I'm going to talk to you about people with primary immunodeficiencies who have antibodies to interferon. So usually we think of antibodies as being a good thing, being protective, but they can also get in the way. And these are antibodies that get in the way of interferon having its effect. And people with antibodies to interferon, fortunately, are rare, but having antibodies to interferon, which inhibits the interferon, is associated with more severe disease. So you're already starting to get this idea. More interferon is good, less interferon or blocked interferon is bad. And then the data that I'm going to show you is that people with interferon pathway mutations have more severe disease. So I'm going to summarize all of these papers. So I know people are frustrated because it seems like research is taking so long and we don't know anything about the infection in people with primary immunodeficiencies. But actually, since Maria and I first came to this forum a few months ago, there has been a ton of research. And so I'm just going to put up the mini papers. And I just got back, meaning virtually, from the European Society meetings, and there was even more data presented there. So if you move on to the next slide, Kathy, I will sort of summarize what all of these studies are saying. So mortality rate is a sad thing to talk about, but it is kind of the common denominator across all of these studies. So some of the studies also measured the rate of people going to the ICU, the rate of hospitalization, but not all of the studies did. So when I combined them, I had to use mortality rate. And so I'm going to try and paint a picture that's largely reassuring, which is not to say that I'm minimizing the anxiety and the risks. I don't want anyone to get COVID-19, not anybody at all. But in fact, it's largely good news about people with primary immunodeficiencies. So over on the right is the case fatality rate from different countries. And these data were collected in the same way that the data were collected over on the left for people with primary immunodeficiencies. And so if you look up mortality rate, you'll see that in the US, the case fatality rate is about 1%, whereas in this chart, it's listed as about 5.5%. And that's because these data were collected comparably to the way the data were collected for all the immunodeficiency studies. So there was no effort made to collect the asymptomatic patients. And so the mortality rate or the death rate is going to look a little different, but I tried to match up studies that collected the data in the same way. Okay, so over on the right, we've got the general population from different countries so that you can appreciate that there is kind of a spectrum. And then over on the left, we've got the amalgamated data from all of those studies that I shared with you. And so the mortality rate is 10% in common variable, 0% for XLA, 0% for hyper IgM, 14% for chronic granulomatous disease, 10% for hyper IgE, and 8% for immune dysregulation. Now, if you're not familiar with that term immune dysregulation, it implies people who have susceptibility to both infection and autoimmune disease. So a fair number of people with common variable kind of fall into this immune dysregulation category, and we often kind of partition patients differently. So if you sort of look across the classic primary immune deficiencies that are often well represented at the Immune Deficiency Foundation, the mortality rates are actually fairly comparable for the mortality rates in UK and the Spain. Remember, this is an international set of patients. So it's not just US patients. In fact, the international patients dominate. So overall, I'm going to say that the risks are not dramatically elevated in people with the classic primary immunodeficiencies. Now, again, I don't want to minimize that there's been a lot of pain in the PI community. And so that's not to say that I'm just going to throw open the doors and say that people should do whatever they want. I do think that there is reason still to be cautious, and we'll get into that, but it is overall reassuring data. Now, because the patients with common variable constitute the single biggest group, we've been able to do a little bit more of an analysis. So among patients with common variable, age was the biggest predictor of death, which is precisely the same as the general population, right? The very elderly have by far the highest risk of death. Same is true in common variable. In common variable, chronic lung disease also increased the risk of death, but again, that is also true in the general population. So I want you to take away from this that there's kind of an additive effect of risks, which we know is true in the general population. And it's also true probably for most people with primary immunodeficiency. So as important to ask what does add to risk of death is to ask what does not add to risk of death. And this has been a bit surprising as well. So certainly at the outset, I was much more nervous about the people with immune dysregulation. Remember, that's defined by infections plus autoimmunity. I was also nervous about my patients with autoinflammatory diseases. These are diseases that are typically associated with arthritis, inflammatory bowel disease, where inflammation is a big part of the disease process, because we know a lot of what drives the severe outcome of COVID-19 is inflammation. So I thought people with autoinflammatory diseases that already have a lot of inflammation would be at increased risk, and that actually has not turned out to be the case at all. Importantly, having a T-cell immune deficiency is not a major risk factor for death. Now, for most respiratory viruses, having a T-cell immune deficiency like HIV is actually a big risk factor, but not for COVID-19. So there's a report of a child with very few T-cells who survived. And then from our institution, there's a report of a baby who had she's a toddler, very few T-cells. And she survived just fine. In fact, she giggled at me for about 32 hours and then we sent her home. So I think there have been a lot of lessons learned about COVID-19 that weren't obviously extrapolatable from our previous experience with respiratory viruses. So are there any primary immune deficiencies where there's an increased risk of death? Yes. So Good syndrome is actually not a primary immune deficiency. It's a secondary immune deficiency related to a tumor. And this tumor is called thymoma. And typically this arises in 60 and 70-year-olds. And as a result of the tumor, the patients develop absent B cells, and they can have a significant risk of both autoimmunity and infection. So this isn't classically a primary immune deficiency, but we often sort of lump it together because it looks like other immune deficiencies. But these patients develop a very high level of antibodies to type 1 interferons, and the mortality rate in Good syndrome has been about 50%. Now, there's also an age component because this is a tumor of the elderly, but we think that the biggest driving force is these blocking antibodies that interfere with the function of interferons. Very similarly is a condition known as APSED, or sometimes APS1. This is due to mutations in the AIR gene. And these folks have candida usually throughout their life, but they also develop autoimmune destruction of their endocrine organs. And they also produce very high levels of antibodies to type 1 interferons. And there does seem to be an increased risk of mortality in this condition. And then there are some interferon genes. Now, this is from an amazing study that was a large international consortium that studied largely patients in Italy that did not have any obvious features that put them at risk for severe COVID, and yet they landed in the ICU. And so there was this massive sequencing effort to try and find gene mutations that might explain why they had severe COVID. The genes that they found are listed in this slide, and this pathway that I've drawn here with all these arrows is basically the pathway for both the production and the sensing of type 1 interferons. And there's a series of genes that were identified, but they all impact this interferon pathway in different ways. So the big square cell at the bottom is meant to be the cells that line our respiratory tract. A virus lands on those cells and the cell understands that it's infected, starts producing type 1 interferons, which then land on the cell next door. And the idea is that the next door cells will pull up the gangplank, they'll close the shutters, they'll lock the doors, and it will protect them from getting infected. And that's called the ISGs, for the interferon stimulated genes. So all of the gene defects that have been identified with severe COVID are in fact mappable to this pathway. Well, what do these patients look like? So they do not have recurrent infections. They do not have bacterial infections. They don't have a history of severe infections. They're not on immunoglobulin. They just had severe COVID. And that is a huge surprise. You would think if your interferon pathway was compromised in some way that you would struggle with all viruses, but that is not the case. Although interferon is produced in nearly all viral infections, SARS-CoV-2, this specific virus, seems to understand the level of interferon more sensitively than other viruses. So how can these people with these how can people protect themselves? So there's some options. So you're going to hear from Dr. Gutierrez in just a couple of minutes about vaccines. There are some antiviral medications that I'll talk about, monoclonal antibodies. And then I know everyone wants to know, when will IVIG confer protection? And I will talk about that, although I don't have very much of a concrete update. So first, the antiviral drugs. So you're probably familiar with remdesivir. That's been around for over a year at this point. It shortens hospitalizations by a few days. We give it to all of our hospitalized patients, or almost all of our hospitalized patients, as sort of an act of faith. It is not magic by any stretch, but at least statistically, it seems to shorten hospitalization. You might have seen in the news just this week that there's a new drug produced by Merck called molnupiravir. This is an antiviral drug that they are submitting for emergency use authorization. And no one has seen the data yet, as far as I know, but it is said to be very effective, more effective than remdesivir. So if they submit for emergency use authorization in the time frame that they say, this should be available sometime around Thanksgiving. You will notice that I have grayed out hydroxychloroquine and ivermectin. So let's start with hydroxychloroquine. Got a lot of press early in the pandemic, but now there have been quite a few studies looking at hydroxychloroquine. It does not protect from disease severity. In addition, the mortality rate is higher in the people that get hydroxychloroquine. So that's definitely off the table as far as I'm concerned. And then so much mythology about ivermectin. So ivermectin is a drug I've used quite a bit. It's used for kids and adults that get tapeworm, but pound for pound, this drug is used primarily for cow tapeworms, tapeworms being a kind of icky parasite that honestly, it's exactly what it sounds like. So really no difference in symptom resolution, but again, a lot more adverse events with ivermectin. And it doesn't even make sense. Why would a parasite drug work on a virus? But it's just gotten so much traction on the internet, and there actually are countries that do use it sort of as their national policy. So it's really gotten a lot of traction for reasons that totally escape me. Let's talk about the monoclonal antibodies. So the monoclonal antibody that is currently available is produced by Regeneron, and the brand name is Regencov, but it's a combination of monoclonal antibodies. It is approved for people over 12 years of age, and it cut the hospitalization by about 2/3. So it does seem to have a genuine effect on progression of disease. It's administered within 10 days from the time of diagnosis. It is most effective early. So if you can manage to get it within the first few days of a positive test, it's actually more effective than on day 8, 9, and 10. But you are allowed to give it within 10 days of a positive test. There are some clinical exclusions in the way it was authorized, and it is approved for post-exposure prophylaxis. So the initial indication was people that were early in the course of infection but did have symptoms or what were otherwise known to be positive. but it has just recently been approved for post-exposure prophylaxis. So let's say you are working somewhere and a colleague comes in and coughs all over you, and they subsequently are found to have COVID-19. You can now get this for post-exposure prophylaxis without actually developing the illness yourself. Sorry, I should have said these monoclonal antibodies, I think, are a great safety net for people with PI. So we administer them in my institution. They're available at most academic institutions. If you live in a very rural area, you might have to drive to get it. But most academic institutions today are offering it, maybe more on the adult side than the pediatric side. But that monoclonal cocktail is actually pretty available these days. But the question everyone wants to know is, when will my immunoglobulin protect me? And so the answer is we don't know. So I know the senior author of this paper, Thomas Kreil, and I have really pestered him quite a bit leading up to this forum to try and get an answer out of. So this paper came out, I think, way back in February. And in a model, based on what they were seeing already at the time, they predicted that immunoglobulin products that hit the market over the summer would have protective levels of antibody. But that's a model. And sadly, we still don't know what a protective level of antibody is. So, excuse me, what he has said is that they have completed their measurements of the products and they're rerunning the model with the new measurements, but he won't share the data with me until he's finished his analysis, which I respect as a scientist, although I found it a little frustrating for tonight. But he says, rest assured, the data will be released soon. So his prediction back in February was that immunoglobulin products would be protective over the summer. Most plasma comes from the US, not Europe, and the US is now lagging a few key countries in Europe in terms of immunization. So excuse me, there's no substitute for actually measuring the levels. And again, we don't exactly know what protective levels are. So now I'm going to turn it over to Maria, fortunately just in time since I've developed a cough apparently, and she is going to talk about the vaccines, and there's some lovely data that she's going to share with you. So let me introduce Maria Jimena Gutierrez. She's from Johns Hopkins, and she is going to take over from here.
So thank you, Kate, and thank you for the invitation to the IDF talk tonight. So I'm gonna start just recapping a couple of things that we mentioned during the previous talk, so that actually have been updated recently. So as we know, in terms of vaccines, we have 3 FDA-approved vaccines in the US. One of them have definite approval. The other ones are emergency approval. Those are 2 mRNA vaccines, the ones manufactured by Pfizer and Moderna, and 1 DNA vaccine manufactured by Johnson & Johnson. They have some differences, especially between the mRNA and the DNA vaccines, but essentially what they do is that they have the genetic material that is able to release instructions to cells to make the spike protein. The spike protein is the protein that is in the envelope of the coronavirus and is kind of the ID for the virus. The way it's one of the proteins that is presented to our immune cells in order to tell, hey, I'm here. So how the vaccines work, they have a similar mechanism. So they carry the genetic instructions to make spike proteins. They release them inside the vaccinated cells, and that actually triggers our immune system to produce 2 kinds of responses. The first one is one that we call the cell response, is when our immune cells teach the killer T cells how to actually go find and kill infected cells that have COVID inside. And the second arm of the immune response is actually the one that is led by B cells. They are actually instructed by other immune cells to make antibodies. Those antibodies are released into fluids and actually reach coronavirus when they enter the body, code them, and that tags COVID for destruction by other immune cells. So I want you to keep these two in mind because we mention it later when we talk about how we respond to vaccines. So more on the clinical side, how effective have been COVID vaccines. So when we first talk about here, we had information mostly coming from clinical trials. We knew since the initial trials that these vaccines were very, very effective. We're gonna talk a little bit what has happened later with the new variants, but in general, the data about effectiveness against the original COVID variants was impressive. We had a couple of vaccines that were over 90% effective at preventing symptomatic infection, and some of them near 100% effective at preventing severe outcomes by COVID-19. And we had the Johnson & Johnson vaccine that was a little bit less effective, not saying that that vaccine was bad. It was actually very good. And their effect, its effectiveness was near 80% against severe disease. That was was over 80%, I'm sorry. That was the main outcome that we were tracking. The good news is that we now have data in over 380 million doses that have been applied in the US. And these initial data actually replicated in real world data. So what we know so far is that in general, all three vaccines approved in the US reduce the chances of infection and hospitalization by more than 80% in most cases. You see that for the Pfizer and Moderna vaccines, especially for the Pfizer vaccine, there was a trial among residents of nursing homes that showed a little bit decreased effectiveness, around 64%, but that was a special population. Other studies in all other populations, including high-risk populations such as healthcare workers or patients with high levels of exposure to COVID, was excellent. These vaccines were very, very effective, and that has been proven in real life. In regards to the Johnson & Johnson's vaccine, that has performed really well as well. It's less commonly used in the US, but the rates of protection against symptomatic COVID and severe outcomes is pretty robust as well. In regards to safety, we initially discussed information from clinical trials. That was the first one, the first information that we had available. That information was very reassuring in terms of safety of these vaccines. Those were trials that were conducted in thousands of people from diverse backgrounds, from a variety of medical problems, with very detailed symptom monitoring through extensive diaries of symptoms. And the vaccines were very safe, and that's basically what allowed their approval for emergency use by the FDA. The good news is that these data has also been replicated in real world. So as we said, as of August of this year, there were approximately 386 million doses of COVID vaccines applied in the United States, and the vaccines still perform very well in terms of safety as well. So what we know in terms of side effects is that the most common side effects after COVID vaccinations are frequent but mild. So we may have local reactions at the site of injection, such as pain, redness, swelling, and we may have kind of a flu-like symptoms that may last for 1 to 2 days in a number of people, but in general, those are limited and are self-resolved. We also have heard about rare side effects. They have been reported. You have seen them in the news. They are mostly of 3 types outlined here. The first one, we have seen severe allergic reactions a little bit more frequently with the Pfizer vaccine than with the Moderna vaccine, but still pretty rare. The numbers are here. There is approximately 11 cases of severe allergic reactions per million doses of the Pfizer vaccine applied, 2 per million with the Moderna vaccine. Importantly, about a third of this doesn't happen randomly, because about a third of the patients with these reactions are patients who had a history of severe allergic reactions to other vaccines or agents before. And importantly, even we know these reactions exist, they exist with other vaccines as well. And actually, when comparing the numbers that we get in terms of severe allergies to others, we see that the COVID vaccines perform, I mean, the incidence is comparable or maybe a little bit less. The second side effect has been the thrombosis syndrome reported in association with the Johnson & Johnson vaccine. There is no causality that has been proven. It's an association, is something that has been a clinical observation. It's rare, about 7 events per million of doses applied, especially in women under 50 years of age. It's still very rare. And finally, with the opening of vaccinations to young populations, we have seen, especially in young adults, especially males, that the Pfizer and the Moderna vaccine, the second dose, has been reported in association with myocarditis and pericarditis. That has happened. There are recent reports, the most recent in JAMA this week. The frequency is still pretty low, about 5 cases per million doses applied. So in summary, what we know is that severe side effects to COVID vaccines may happen, but they are very rare. And in general, the risk of having one of those is very low, and the risk benefit of getting the vaccine always favors vaccination. So now that we have very effective vaccines available to everybody in the United States, where are we? So we had the worst time in the winter of last year. We saw the effect of the massive vaccinations with the lowest point of the pandemic in June of this year. Unfortunately, we are now in the middle of another peak when cases are increasing again. And there are several reasons to that. The first one is that we have seen the emergence of more contagious variants, mainly the Delta variant. This has been a very contagious agent, a variant that kind of pushes other variants away, at the point that today accounts for 99% of cases in the US. It's much more contagious. Here it says twice, but we don't know if maybe more than that. Just watching the behavior of these ones, we know that this variant has gotten a little bit smarter about evading the immune response. We have seen that in the lab, that because this vaccine, the antibodies against COVID are not as effective as against Delta as they are against other variants. The vaccine effectiveness is also a little bit decreased against symptomatic infection, but importantly, and this is probably the main message from this slide, it remains very, very high against severe infection. So vaccination is still the best measurement against this variant. So we have seen actually the data from the US replicated in other countries. As we see here, the effectiveness of the vaccine against Delta, which is in red, is decreased. It may be decreased against for symptomatic and mild infection, especially for the Pfizer vaccine, but the data that indicates protection against hospitalization and severe outcomes is reassuring. Protection is still high, and the data are very robust. So another concern is that immunity may be decreasing, and that actually several studies have shown that, especially with the Pfizer vaccine. That's one of the reasons why a third doses is now being recommended. Protection against symptomatic infection may drop. However, the rates of protection against severe illness, even for high-risk patients, even for high-risk populations, is still pretty robust. So who is driving the number of hospitalizations and deaths in the US? Unfortunately, the unvaccinated. As we see here, this is data from the CDC regular updates as of September 23rd of this year. In all age groups, the majority of patients that go to a hospital are patients that have been unvaccinated. Saying that, there is a small percentage of patients with what we now call breakthrough infections. Those are the infections that occurred among people that have been fully vaccinated. So who are they? We mentioned them here because this is pertinent to our community. About 3% of the US hospitalizations are breakthrough infections. They are 70% of those patients are people who are 65 years or older, and 44% of them are breakthrough cases. Of the breakthrough cases are immunocompromised people, and that is not only immunodeficiencies, but all patients in the category of with primary or secondary causes for immunocompromise. So saying that, one of the main questions since the beginning of the vaccination campaign has been how primary immunodeficiency patients respond to vaccinations. And actually, there is data that is starting to emerge to answer that question. Unfortunately, we don't have large studies yet, but they are underway. But from the data that we have, specifically from a small study in Israel, we know some things. Number one, they actually had 26 patients with several types of immunodeficiency. Among them, most of them, including patients with innate deficiencies, antibody deficiencies, combined immunodeficiencies, seem to produce antibodies and cellular responses against COVID. There are a few exceptions. One is patients with XLA, or some patients with immunodeficiencies that have low B cells that seem to produce a little bit less antibodies, but they are like very few patients. However, they have good cell responses. On the other hand, there are some patients that may have decreased T cell responses, but they still make antibodies. So how that relates to risk of infection, we don't know yet. Data is still scarce. There are studies that are still being conducted, and hopefully we'll have more information soon. So what do we do in the meantime? So the first one recommendation is get vaccinated. This is still safe, effective, and protects even for people with weaker immune systems. Saying that, patients with immunodeficiency may not be fully protected, so still need to take precautions for unvaccinated people. We are familiar with those: masking, social distancing, hand washing. Vaccination not only of patients but of close contacts is very important. As Kate mentioned earlier, monoclonals for early infection or for prophylaxis are a very useful resource. And recently, the third vaccine dose. So who are the patients recommended to get a third vaccine dose? So there is one group that should get vaccinated 6 months after the second dose of the Pfizer vaccine. Those are people who are 65 years old, people with medical conditions, adults with medical conditions, adults in high-risk settings, or adults who live in high-risk settings, such as long-term care settings. And there is a second group that actually needs a vaccine, a third dose, regardless of what vaccine what mRNA vaccine they received initially, either the Pfizer or Moderna, and at least 28 days after the second dose. Those are patients who are considered severely immunocompromised and include people under treatment for malignancies, people who have received a solid solid organ or a bone marrow transplant, people with severe immunodeficiency, and people treated with immunosuppressive medications. About what defines a severe primary immunodeficiency, we have had several discussions about that, and currently there is no consensus because there are several factors that play in that decision. So our current recommendations is that you should discuss with your immunologist your individual case in order to decide whether or not you are in this group. What about other vaccines? For the Johnson & Johnson vaccine, we don't have data about whether you're gonna need a booster. However, a panel at the FDA has been recently convened to make a decision about this, and we should have information soon. In regards to what other things can be done to know whether or not if you responded to vaccine, there is a question about whether you should be tested. The current recommendation is not on the routine basis, and there are two reasons for that. Because number one, we don't know yet what is the standard or the acceptable level of antibodies that means that you're protected against COVID. And number two, because testing at commercial labs may not be standard. So what can you do for now? I think that's one of the most important questions. So recommendation number one is get vaccinated. Vaccine for you, including the third dose. Vaccine for your contacts. Vaccine for your kids older than 12, and hopefully for younger once the vaccine is approved. You still need to take precautions, including mask, social distancing, and hand washing, but that has to be balanced with taking care of yourself, including mental health, because we know anxiety and depression are major problems of the pandemic and also have affected our community. So what else you can do? Stay connected among yourself, family, friends, us, and don't forget that we're here for you. So saying that, I want to thank you, and we are open for questions.
Thank you so much, Dr. Sullivan and Dr. Gutierrez. Wonderful, wonderful information. And now we are going to switch over to the Q&A session. I would like to introduce my colleague, Colleen Brock. She is going to moderate the session for us. So Colleen, go ahead, take it away.
Good evening, everyone. I'm going to start this off real quick with we have over 200 plus questions. So it's not going to be possible to answer everybody's questions, and I will apologize up front, but we are going to do our best. So I have them broken down into various categories. I'm going to do a couple from each, and then we're going to go back and do a second round and do it that way. So Dr. Sullivan, is the booster shot for COVID the same strength and composition as the other two shots?
Yes, it is. And that means you can get it at any pharmacy, wherever you got your first shots, you can go back there. It's widely available. Many CVS here on the East Coast, many CVS and Rite Aid pharmacies carry it. So it's not hard to get the booster, and they're not really asking for anything other than, I think, for their record keeping, what condition brings you there. So you should try and match it to what you had for your first two doses, but you actually don't have to.
And that is my second question. I'm fully vaxxed with Pfizer and wanted to know if I can get the Moderna booster, and if that would be more advantageous, scientifically, immunologically speaking, for my body to get that instead of the third Pfizer.
Yeah, the Pfizer and Moderna are pretty comparable. And so I would say there's not any gain or loss from switching it up. There's enough data right now to suggest that it doesn't make any difference whether you boost with the same vaccine that you had for your first 2 doses or a different one. The J&J is a little bit of a different story. So that immunologically is a smidge different. And I have recommended that to some patients that had adverse events with the mRNA vaccine. Or actually vice versa. I've had more patients get adverse events with the J&J vaccine, and then they've switched it up and done their second dose with an mRNA vaccine. So as Dr. Gutierrez said, the J&J vaccine is going up to the FDA this week to get emergency use authorization for the booster part. And so there's not as much data trying to mix and match mRNA with J&J, but there's a little bit of data from Europe, and it suggests that mixing and matching is just as effective with the J&J. So I would try and match it, but if you have a reason to switch it up, certainly don't sweat it.
Thank you. Timing of the next booster for those who just got their 3rd vaccine. Can we safely wait to get, is it safe to get more vaccines over the next year? And if so, how many COVID vaccines should one receive, period? Because there are some people who are frustrated with not producing antibodies. So they are getting 4, 5, 6 vaccines trying to get a positive antibody test.
Goodness gracious, that's a lot of vaccine. So remember, let me say it another way. I'm actually going to answer a slightly different question, if I may. And if you're not happy, you can re-ask it to Dr. Gutierrez. So I would just remind everyone that patients with common variable, 80% make antibodies after the vaccine. So if you have common variable and you didn't respond to Pneumovax, you didn't respond maybe even all that great to tetanus, there's still a good chance you're going to respond to these vaccines. They are very powerful vaccines, and that's in part where they have some reactogenicity, meaning the fever and the sore arm. So it's a relatively small slice of the pie of the PI community where we don't expect people to make antibody responses to the vaccine. And that would be largely men with XLA, and then a small subset of people with common variable. And again, I don't want to diminish the anxiety that comes about because of lack of response to the vaccine. But I would say, don't just think that you might not make antibody, because there's a good chance that you will make antibody. But if you have no B cells in your body at all, if you don't have the cell that's capable of making antibody, I would not keep flogging yourself with more and more doses. So there are some data from transplant cases that demonstrate a 3rd dose will move people out of the non-responder category into the responder category with that 3rd dose. But there's no reason to believe that 4, 5, 6 is going to move you from being a non-responder to a responder.
Yeah. In addition to that, thank you, Kate. We know that patients, even when you don't make antibodies, you still respond with your cells. So there is an arm of the immune response that is not being measured by the antibody testing like necessarily. And number 2, as Kate say, yes, like most patients with 3rd dose in other type of immunodeficiencies, it show that they go from the non-responder zone to the responder zone.
Thank you. And next question for you, Dr. Gutierrez. If you test positive for COVID antibodies, could receiving monoclonal antibodies prophylactically be an alternative to receiving booster shots?
I think this is, I mean, they are not mutually exclusively, except for the in terms of timing. I think each of the intervention has a different purpose. So if you have an indication for a booster shot, you should get it. But if for some reason you are, like if for some reason you happen to have an early breakthrough infection, even after being vaccinated, you're in a high risk category, and your doctor determines that you should that you will benefit from monoclonals, you can still go and get them.
Thank you. Is there an antibody test to determine if the vaccine works for a person with COVID, with knowing if we made the correct antibodies that will fight off COVID? This person had their third vaccine and two antibody tests. One said that she had antibodies, the other said she did not. I want to know I am protected so I can come out of my shell. I have been living separated from my husband, who is an ER doctor, and she doesn't know what to believe.
Maria definitely doesn't want to touch that one. Well, I'm going to say, well, this man is your husband. I presume he is vaccinated. So for heaven's sakes, go back to smooching and whatever. I think we need that human contact. So I'm going to start off by saying I fully endorse marriage relations in the whole big category that encompasses, and would not want people to separate because of COVID risk, particularly if the partner is vaccinated. So, but let me come back to the more nuanced part of that question. I just wanted to start by endorsing marriage. And this is a little bit of nuance. So after vaccination, you're going to make antibodies to S protein or spike protein. After natural infection, you're going to make antibodies to S and N primarily. And so the difference could be that maybe they sent the N antibody test for the time where they didn't detect antibodies, and what they should have sent was the S antibody test. But I'm going to come back to something that Maria said, but I'm going to say it more dramatically. Antibody testing in America, actually around the world, is a complete and utter mess right now. So it is not standardized. Every company stood up their own testing. They don't use the same metrics. They don't use the same measure. In fact, if you look at the labels, it's often not the same because people are measuring them in different ways. And so I really discourage people from getting antibody testing right now. I think at some point there's going to have to be some standardization, but right now it's a complete and utter mess, as you just described yourself. You've got antibody tests that are discordant. What on earth are you supposed to make of that? Probably even your doctor doesn't know what to make. And I'm not impugning your doctor. I'm just saying all of us are struggling what to do with these crazy test results that make no sense. So, so this is a long way round of saying, I wouldn't, on the basis of one negative test, sort of say that you have to remain in a closet with all the shutters closed and get all of your food delivered. I think this is the moment, with the cautions that Maria talked about, to say it's time to start folding back in some of life.
So moving on to testing, are the home tests for COVID accurate for people with a PI? I think they're talking about the rapid testing. So either one of you.
Colleen, I was going to say, Colleen, can you specify who you're looking for? Otherwise, Maria and I are just going to stare at each other.
You can do that. So you get it.
So, okay. I get it.
Sure.
Okay, I get it. Both the rapid and the PCR testing, they measure actually factors that are coming from the virus. So one is an antigen-based testing, and the other one is actually a PCR, which is an amplification of the virus genome. So yes, they should be useful in somebody who has primary immunodeficiency, including an antibody deficiency, because they are not related to antibody response. The antibody testing may be a different story.
Okay, and staying with you, Dr. Gutierrez, would you test positive for the nucleocapsid antibody if the COVID antibodies are in your IG product, and positive for the spike protein if you have been vaccinated?
Yes, The
And
answer
then
is
would you
yes.
test positive for the spike protein if you have also been vaccinated?
Yes, the answer is yes to both, because
Okay.
the antibodies may come from both sources, and you don't have a way to distinguish, where they came from. The question is, what level, for how long. Yeah.
Perfect. Last question for you. Any conclusive research on what level of T cell response is protective? And is there an assay to measure T cell protection yet?
The first question, no, we don't know. There is only a small studies. Number two, there are no, most of the assays that we have to measure T cell responses are done in research labs. Unfortunately, we don't have a standardized, commercially available test to measure T cell responses for this purpose. Against COVID-19. So no, unfortunately, no.
Thank you. Dr. Sullivan, wondering what conditions would interfere with interferon? I have a gain of function in the JAK1 gene, which is involved with interferon.
Yeah, that's a very sophisticated question. So a gain of function in JAK1, so that would be predicted to actually enhance interferon. So as far as I know, all of us are reporting our patients into registries, and the Immunodeficiency Foundation, in collaboration with USIDNet, is standing up a new registry to collect both vaccine adverse events as well as the risk of long haul COVID and other COVID complications in people with PI. To my knowledge, JAK1 gain of function has not been reported to any registry yet, and I do try and stay on top of that data. But certainly, just thinking through the pathway in my head, you might even think that having JAK1 gain of function could be protective. So I don't have a perfect answer for you.
Are people with WIN syndrome at a higher risk of mortality, given that our responses to vaccines is highly variable? Dr. Sullivan, I'll let you have that one.
So there have only been a couple of WHIM syndrome patients reported. So at this European meeting that took place last week, there was one, and there's one in the published series that I shared with you. So not a lot to go on, but here's what I would say. I'm going to come back to this idea that even people that don't make good vaccine responses to tetanus or pneumovax or Haemophilus influenza usually will respond to the COVID vaccines because they're just that much stronger. So I wouldn't be too pessimistic about your ability to respond to the vaccine. I think there's quite a good chance that you will.
And last question for you this go round. What do we know about the MU mutation and how it affects the PI community?
Yeah, there's two additional variants that are kind of percolating around at very low levels. There's mu and there's lambda, and they both are if you ever go on the CDC website, they list them as variants of concern or variants of note, because they at least theoretically have the ability to compromise the antibody binding. And so that would allow them to proliferate. But what's so interesting is that they have been both in the US circulating and in other parts of the world circulating, and they have been totally outcompeted by Delta variant. And so the feeling is that Delta variant is just so much more transmissible that even though it's still susceptible to antibody prevention, it's just a much more transmissible virus than all of the other variants that have been described. And so from a community perspective, it just outcompetes everything else. So you're right, everyone is keeping an eye on these new variants that have popped up, but so far, they don't seem to gain traction. They just can't compete with Delta.
Okie dokie, Dr. Gutierrez. Will IgG therapy potentially provide enough antibodies to eliminate the need for the J&J booster?
Well, actually, we don't have information about J&J boosters yet. So I think we'll need to see, what are the recommendations until data, when data emerges about that. So far, there is no recommendation for J&J booster. So.
During my treatment, it states that I should not receive any vaccinations within 3 months. I am currently receiving IVIG every 6 weeks. What do I do?
Patients on IVIG infusions can get vaccinated even if receiving infusions on a regular basis. The recommendation about the 3-month wait was specifically for monoclonals. If you get a monoclonal antibody infusion, you need to wait 3 months before getting vaccinated.
Thank you. Can someone get too many SARS-CoV-2 antibodies from their IG infusions? In other words, a SARS-CoV-2 antibody overdose. Dr. Gutierrez.
Well, actually the amount of, number one, the number of the level of antibodies in IG preparations is still unclear to us. We don't have like recent data. Because of the rates of vaccination in the general population, they should be increasing. So we assume they are higher and higher, but as Kate mentioned in her data, it's still low, relatively low. Number two, we don't have data that allow us to define what is too much. I don't think we have that answer yet. And I don't think that you can get, my personal take is, I don't think you can get too much antibody from IVIG infusions.
Thank you. Dr. Sullivan, I'm going to start back with you again. Children. Is early vaccination for children under the age of 12 with CVID is it okay given recommendations and the data that has come out about the safety dosing of the Pfizer vaccine?
I suspect that there's a specific concern behind that question, but I do think when the vaccine is finally approved for kids 5 to 11, it does make sense even for kids with CVID to get the vaccine. It is a lower dose of vaccine for the kids than for the adults and the teenagers, but I would predict that it's still quite effective. So there's less data on people with other conditions, and there's certainly less data on, kids with transplants and things like that. But by extension from the adults, I think most of the kids with common variable will respond to the vaccine. But as I said, I suspect that there was a specific concern behind that question that wasn't articulated. But on the face of it, I wouldn't have any reservation about making a recommendation for a child to get the vaccine, even with CVID.
I've received a lot of questions about this next one. Do you have any information regarding recommendations for lunch at school during COVID? I'm working with my child's school to find an appropriate location and distancing during the unmasked eating time, but then there's also the mental health concerns.
Yeah. So kudos to the person who asked that question. It is so hard to balance everyone's needs. Brianna Wickoff just sent me a chat through the chat box asking about, what should the schools be doing in terms of allowing sick kids back in school? And I feel like it's the Wild West out there. Every school is home cooking their own answers, and sometimes it changes from week to week. So what about this unmasked during lunch thing? So some schools are trying to pod kids, so you always have to eat lunch with the same group so that at least you kind of limit the exposures. Some schools are having kids eat outdoors. I think the pods are semi-effective. I think outdoors is pretty effective, but I think it's really hard. And whoever asked the question, I think you've really put your finger on it. When you get things too restrictive, you're then endangering some of the mental health. And I do not know where the sweet spot is. I think some of my colleagues are on school committees that have helped to design the policies for their particular school, and none of them ended up with the same policies. So I don't think anyone's got a corner on this market.
Next question for you. Why are children all of a sudden becoming so sick when for the longest time we were told they rarely got sick and were asymptomatic?
Yeah, it's totally the Delta variant. And remember, at the very beginning, I talked about how we can't measure it, but inoculum size, so the amount of virus that enters into a person's body, is a really big variable in terms of outcome. And with the original European strain, and certainly with the original Asian strain, the amount of virus that was produced by an infected person was just much, much less. And so there's just more virus getting coughed onto people now with Delta variant, because it just propagates to far higher levels. And that's driving a lot of the pediatric illness right now.
And last question for you on this topic. Are young unvaccinated children with IgA deficiency experiencing more severe illness from COVID compared to a child with no PI? And I guess that kind of goes for any child with a PI. Are they doing worse than a regular child without a PI?
So far, we should ask Maria as well. For my patients, no. The patients with PI that have been kids, so I'm a pediatrician, have done actually fairly well. And the younger the child, the better they have done. So I have some teenagers that were really pretty punky and missed a fair bit of school, but none of the little kids that have gotten sick have actually done anything other than had a fever and a bit of a cough. So I think it's very comparable to what we see in adults, but just less in the way of symptoms, even with Delta variant.
Yes. On my end, unfortunately, we don't have like very details on children, because we are still collecting data. But in general, what I've seen is that disorders that you will be concerned about possible severe disease have not shown signs of severe disease. They basically get infected and get to overcome the infection with only mild or moderate symptoms at the most so far. But of course, it's just personal experience. I think we still need to gather data and just do like a formal analysis on that.
And Colleen, I'm going to come back to the specific question about IgA deficiency. So Colleen and I had a long email conversation this week as a result of a patient emailing IDF and asking about IgA deficiency. And so what I will say is there's no reason to think on the face of it that people with IgA deficiency would be more susceptible than those with CVID. So I wouldn't worry more about someone who's IgA deficient. And the second part is that there are very few people with IgA deficiency that have been collected, which is really what Maria just said. So I think more to come on IgA deficiency.
Thank you. Dr. Gutierrez, we're going to switch to treatments. Why are people with immune disorders who are going to die if they get sick not getting monoclonal antibodies to protect from the virus?
I'm sorry, can you please repeat that? like why?
This person says, why are people with immune disorders who are going to die if they get sick not getting monoclonal antibodies to protect from the virus?
I mean, it's like, as Kate said, right at the beginning of the infection, there are some predictors of severe disease, but it's really difficult to know for certain. What we're doing right now is that now common practice that if you have risk factors that put you at risk of having severe disease, you have access to monoclonals. I think but it has to be decided on a specific basis. Our main recommendation about this is that you consult with your physician who knows your specific risk factors and your specific situation for decisions about that. But in general, that's what monoclonals are for people at high risk. And if in that category, they should be offered.
I have another question about the monoclonal antibodies. Can patients who get regular IVIG receive monoclonal antibodies if they test positive for COVID? If so, when did they then resume their IVIG treatments?
When they, in general, IVIG treatments shouldn't be stopped because you have a positive COVID test. They should continue regardless of whether or not you have a positive or negative antibody status or because of a recent infection. Does that answer the question?
Yes, thank you. Last question, there's two that fall into this, and that is about long haul COVID. And what is known about long haul COVID in patients with PI, this person has been suffering for months and is wondering if there's any hope in getting better. And another one said there's a study with long haulers who have fatigue and brain fog and the use of Adderall. And I have also read about the hyperbaric chamber being used with long haul.
Okay. You want me to take that question?
Yes, and Kate can chime in too if she's got thoughts.
No, I mean, actually, I asked because I actually, if Kate has something else to say, you please do. Basically,
actually, I went to some talks on long haul COVID, so I probably can.
I mean, I ask because actually long haulers are actually like a very interesting group, like under study right now, because it's a complete mystery. I mean, who are the ones that develop long haul COVID? Number one, what defines that? Number three, what are the symptoms? Number four, what are the interventions? What characterizes them? So, A is that this is an area of active study. One of the things that we know for sure is that vaccine is also good at preventing like long haul COVID because it prevents you from getting the infection to begin with. All right, so Kate.
I actually hadn't heard about hyperbaric treatment, so thank you for mentioning that. There have been a range of interventions that have been tried, including, as Maria said, vaccine as a therapy for long haul COVID to sort of, I'm using air quotes here, kickstart the immune system. And you know, they all work in some people. It's just hard to know what is the best one. So first of all, I am sorry that you have long haul COVID. It does sound really miserable. As Maria said, there are a lot of efforts directed at long haul COVID because if you stop and think about it, the fatigue and the brain fog actually has a little bit of overlap with the fatigue and brain fog that people complain about in CVID. So I feel like if we can get traction with one of them, we'll get traction with both of them. And as I mentioned before, IDF and USIDNet are standing up a survey to try and answer the question, are people with PI more at risk of long haul COVID? So I wish we had a better answer for you right now. I'm sure it would be a dream of yours to have a pill that would make it all go away. And sadly, we're not there yet. So I certainly want to convey our sympathy. It does sound like a really miserable condition. But please be assured, as Maria said, that it's an intensive area for research.
Thank you. Last question, Dr. Gutierrez, for you at this point. If you have CVID, got the vaccine, but need to start Rituxan, will any response you received from the COVID vaccines be canceled out by the Rituxan?
That's actually a very good question. Number one, we know that Rituxan, even in non-CVID patients, may lower your vaccine responses a little bit. However, the cells that actually keep your memory against vaccinations are not touched by, I mean, not all of them get touched by Rituxan. So you should be able to, number one, respond to some degree. And if you have been vaccinated before, you still have the cells that keep your memory that actually are producing your antibodies against the COVID vaccine. So the answer is maybe at some degree, but not completely. And you should still get vaccination and even the third dose, even if you're receiving rituximab. That's actually one of the indications. If you are in immunosuppressants, that's one of the indications for getting the third dose sooner, like within the month after your usual vaccine schedule.
Okay, thank you. Dr. Sullivan, since you endorsed marriage,
Oh, good.
we're gonna go with moving forward. So I'm gonna ask you an easy one first. How long do you wait to see a friend or family member that has recovered from COVID?
That's easy, 10 days. So most of the studies really agree on 10 days. And so although people can continue to be positive by antigen testing past that, it's extraordinarily uncommon to have infectious virus past 10 days.
The second easy one, should we double mask anytime we leave the house?
So, gosh, I reviewed that masking data pretty recently. So I was really surprised at how much more effective double masking is. So I personally don't do it outdoors because I think the risk of bumping into virus outdoors is limited, but you should do what's comfortable for you. But if I'm indoors and around people I don't know, I do think it's a good idea. When I looked at the data, I was quite surprised at how much more efficacy you got from double masking. So I thank you for asking that question. I think sometimes we neglect kind of the nuts and bolts of what we all call social distancing and protective effects like masking.
And what about for children? Do you have particular masks you prefer or recommend, or double masking for children over the age of 2?
So first, I'm going to, again, answer a different question. I have been so impressed with kids, even some of my patients who have autism. Boy, you know, they really are not rebelling against the masks at all. I am just so impressed with how resilient kids have been throughout all of this. But you actually do ask an important question. So I think getting a mask on their face is really the most important thing. But I think if you can get a mask that's fitted, so you may have seen these KN95 masks. They're 100 times more comfortable than N95 masks. So, and they are made in child sizes. They're not pretty, they're not decorated with SpongeBob, but they do fit the face more carefully. And so if your child will accept a KN95, that's probably your best option. I think getting 2 masks on is a big lift for most children. But again, if they're willing to do it and can manage it, it would offer you 2 masks are almost as good as an N95. And if you've ever worn an N95, you know, they're quite uncomfortable. But a KN95 is actually a good compromise, I think.
Thank you. Okay, now I'm going to hit you with the big one. There are a lot of people who are using words such as paralyzed with fear, terrified, being told I may not leave my house. They're not going to the doctor. They're not going to the dentist. They're not having their mammograms. They isolate at home. And they're all wondering at what point can they come out and how do they come out? So for instance, I'm paralyzed with fear of getting COVID, so I don't leave my house, and I have not let anyone in my house since last March. I've not seen the doctor, the dentist. How do I know when it's safe? Staying 100% isolated with everything being delivered to my house. I've been vaccinated, but I don't know if it's even safe to walk in my neighborhood where no one wears a mask. Another one, I'm still advised to stay masked and not to go inside anywhere. At what point do I go to the dentist, the ophthalmologist? My friends want me to go to a bar for a trivia game. How do we move forward? This isn't going anywhere anytime soon.
Yeah, Colleen, you really left the thorniest question for the end. So first of all, I really feel for the people that went into total lockdown. I understand how you got there, absolutely. And I have a couple of patients that are still doing that, and I have a friend who is still doing that. And I recognize and acknowledge that everyone has a different level of risk aversion, and it's neither wrong nor right. So I'm not pointing the finger at people that are in still lockdown, but I want you to stop and think about the life that you're leading and how much risk you are willing to accept. And I want you to also ask if this is a little bit of PTSD, the just burden of fear of trying to face this big unknown, if it's actually just rewired your brain so that you just live on DEFCON 5, high anxiety every single day. For some of you, that will be the case. For others of you, no, you've made this very rational decision. You've assessed the risks. You've read the literature. You've listened to all the forums, and you still are coming down that you cannot accept even a millimeter of risk. And so for those of you that came at it more rationally and have really thought about it, then please be at least willing to revise. So if you live in a part of the country that has relatively low transmission rates, so the East Coast, the West Coast, some little patches of the North have quite low rates right now, whereas the South has rather high rates, as well as a couple of states in the North as well. So assess your local transmission. Assess your personal risk. So both Maria and I have tried to really look hard at the data. And while people with primary immunodeficiencies have been told their entire life by their immunologist and their doctors, oh my gosh, you're fragile. You have to really worry about every exposure. You have to coat yourself in Purell every day. You've been told that your whole life. And now there's this scary virus that shows up, and it seems very threatening because you can't measure it. You don't know exactly what the risk is, but certainly the data do not suggest that people with PI are unduly susceptible to ICU or mortality. Now, again, let me say again, that doesn't mean I want people to get COVID. Of course I don't. But if you just step back and say, are my risks higher than my neighbor who is the same age who doesn't have PI? Unless you have an interferon defect, your risks are roughly the same as your neighbor who's the same age. And so with that framework, what risk do you accept? Going outdoors, very low risk, unless you're standing in close proximity and laughing at each other. So going outdoors for a walk, I would say it's a kind of a nice baby step that I tell my more risk averse patients to try, just to get a little sunlight on your skin. And then the next big hurdle I have them is to do an in-person doctor visit, not just a telemedicine visit. So doctors' offices are super paranoid, dentists even more. I cannot believe my dental office. And so pick something like that and take some baby steps, and then step back and reassess how you feel, and then gradually try and liberalize to the point where you meet your own risk tolerance. But this is a moment to try and do that.
Thank you. I think it's really important that, like you said, we look at both physical and mental health. And it's important that there's hope. And I cannot thank the two of you enough for the work that you did putting into your presentations, being here tonight, answering the questions. I apologize again that we didn't get to everybody's questions, but I hope that you have learned a lot and that you feel better as to where things stand. IDF is here for you. We will continue to follow everything that's new and coming. We know there's more, and we will be glad to answer your questions as best we can with the data that we know. So both Dr. Sullivan and Dr. Gutierrez, thank you so much. Thank you for volunteering your time. Your knowledge is amazing. Your presentation was fabulous, and it is greatly appreciated by myself, the staff at IDF, and I'm sure every attendee here. So thank you very, very much. And with that, I'm going to pass it back to Kathy.
Oh my goodness, amazing. Thank you so much. Unbelievable. All right, well, we are getting close to the end here. I would like to also thank our featured sponsors tonight: CSL Behring, Grifols, Takeda, Accredo Farming, and X4 Pharmaceuticals for being here, sharing information with us. And once again, thanking our wonderful sponsors and thanking each and every one of you for being here, hanging in there till the end, asking such amazing questions, because your questions definitely help make this program what it is. And your attendance makes this program what it is. And being connected to IDF makes all of us in the PI community what we are. So have a wonderful evening. Take care. And I can't wait to see you next time. Good night.